Going strong. Okay, now we're all here. Good morning, everybody. My name is Morgan Denny. I teach the primary care online course for the Institute of Clinical Excellence. Welcome to the PT on Ice Daily Show. Today, we're going to kind of talk about a new approach to looking at obesity. So I've done talks on this podcast before. Speaking of which, this is the 1001 episode. Pretty rad. But I've done talks on this before, kind of talking about how much I truly believe that it is our responsibility as healthcare professionals to talk to patients about their weight when they are obese or overweight, when it is appropriate. You know, obviously in some cases and for certain patients, this is not always a key factor or something that is safe, but for a lot of people, this is a big piece of their overall health as well as their PT problem. Right? Because obesity and being overweight doesn't just affect people's orthopedic or general physical body, right? It increases the risk of cardiovascular disease. It increases your risk of diabetes, of sleep apnea, of fatty liver disease. Now it increases your risk of having severe COVID-19. It does a lot of things, right? So this is something that as PTs, as healthcare professionals, I think we really need to step into the space of being able to talk to people about this kind of stuff because we have this information. It's something for us that's really easy to measure, right? Like we can do BMI calculations with some fairly simple math or honestly just cheat and use the chart, way easier. And just honestly by general observation and talking to a patient. You know, and I think since we have this knowledge, this information, of how a person's weight can affect not just their knee pain or their back or whatever we're treating orthopedically, but also their general health and how well their body is going to behave and respond over time. I think it's our responsibility to be able to talk to patients about this and give them options, especially if they are willing and ready to get after it and make a change, right? So a recent article that I read in JAMA really kind of inspired me to talk about this again and to talk about it in a new way with a new approach. I assume that most of you out there know that obesity is a problem, right? That I don't have to convince you, but just to throw some numbers out there because it's always good to have them. About 40% of our population is currently considered obese. That is to say they have a BMI of 30 or higher. That doesn't even include the people who are considered overweight via BMI. Now, within that, 1 in 5 children are currently obese, and it's expected that actually by the end of this decade, so in 8.5, 9 years, about 50% of our population is going to be obese. So with numbers like that, if you are treating people in the general population, there's no way that all your patients are outside of this zone of obesity. There's no way that you're treating people who are only very average normal builds. So this is an issue that we've got to get good at, not just because this weight thing will affect their orthopedic body or the problem we're treating, but because we have got to get good at some of these conversations and be a better part of the solution. Now I know, it's a lot of people know they're obese, right? And I think honestly, we often think about it that way too. PTs have this mindset. They're like, well, this person obviously knows they're overweight. I'm sure they understand it's bad for them. They've probably tried losing weight before. That's not what they came into PT for. I don't want to have that conversation. But honestly, I think some of these viewpoints are just excuses. They're not realities. They're just ways for us to avoid a really uncomfortable conversation that honestly, I think it's our responsibility to have. We can't assume that people just have tried everything or that they know all the consequences of carrying a heavier weight. And it's hard to delve into some of those lifestyles and barriers that exist in people's lives because they're real and they're not always easy to deal with. But I do believe it is our responsibility. So let's talk about this article a little bit. This article's focus was actually on a new drug called semaglutide. It's being used for weight loss in patients, and some of the initial trials have recently come out and they've been very successful. Now I know as PTs, our initial reaction to pharmacotherapy is hiss, boo, but hear me out. For this drug specifically, patients who were unable to lose weight in other ways and forms, when this drug was combined with exercise and nutritional therapies, people lost up to 20% of their body weight and were able to maintain that weight for for a long period of time, right? With the effects being ongoing, unlike a lot of the diets and kind of previous pharmacotherapies where patients lose weight and then bounce right back. So this one's really positive, right? And at 20% of a body mass reduction, that's enough loss to actually start to incur some of the benefits of weight loss. Whereas a lot of drugs and previous ideas, it's like if a patient loses 5%, that is awesome. That is by far better than not losing at all, but it's not often enough to prevent the diabetes. It's not often enough to prevent some of this cardiovascular injury. So if we can if we can have our patients lose more weight, get that higher percentage, that could be better and more effective in general health statistics for some of our patients. Now, one of the barriers talked about in this study is actually how medicine historically approaches obesity, right? Current thinking regarding obesity is that it's a disease, like we would think about cancer. And I think we need to start approaching it that way too. So I want to read you a couple direct quotes from the article. These are basically quotes talking to healthcare professionals and experts in the science of obesity and doctors that treat obese patients consistently. So the quote starts now. When we tell patients they need to just eat less and exercise more, we tell them that we don't understand the disease of obesity. There's a whole science behind it. It's not just lack of willpower. Without a recognition that the calories in, calories out model is oversimplified, physicians will continue to advise patients with obesity to just try harder, a strategy that for most is destined to fail. It's not for lack of trying. Biology drives eating behavior. You can reduce calories for a certain amount of time, but at some point, your body is going to tell your brain that you're starving. The body is programmed to store fuel, aka fat, as a safeguard against famine. The amount of fat it holds onto is tightly regulated, a concept termed the energy set point. When a person loses weight, the body compensates by both slowing its metabolic rate and altering hunger and satiety signals to compel eating. Its goal is to return to its set point, which an individual experiences as their typical weight range. The realities of body weight regulation mean the deck is stacked against those aiming to achieve and maintain a substantially slimmer physique. This is especially true for people with obesity, which is now understood to be a dysfunction of pathways involved in energy regulation, with both genetic and environmental contributors. If you have a dysfunction of that regulation system, you defend a higher body weight set point. Anti-obesity drugs and bariatric surgery may succeed where diet and exercise alone often fail because they recalibrate the physiologic set point. The goal of using these medications isn't weight loss, it's to decrease the body fat mass set point, and a byproduct of that is decreased weight. So there's a lot in there, right? Realizing, number one, that a lot of times we as PTs can often oversimplify. Like I know historically I've used the whole calories in, calories out thing. You've just got to eat less calories than you're burning and your body will lose weight, which in many ways can be true. And for some people who aren't predisposed to obesity or whatever, it works. It totally works. But there are a whole host of people, and I've worked with them certainly, who are really trying hard and doing the right things that you're advising, and it's not working. It's not changing. And it's because of this physiologic set point where your body is always kind of getting you to come back to that level that your body's gotten used to. And it's hormonal, and you're getting signs from literally hormones released from your stomach and intestine that go to your brain that say, you have to eat. You have to eat more. You can't stop now. You're not full. These are all things that are happening that are not totally under our control. And so sometimes it's good for us to realize that there's stuff going on behind the curtain that is not just people's lack of self-control. So I want to read you just a little bit more from this article. Over the lifespan, many culprits aside from food appear to have the potential to dysregulate the body's weight control mechanisms, including commonly prescribed medications, poor sleep and circadian rhythm disturbances, pregnancy, stress, pollutants, and the microbiome. Even infections may play a role, but people without an obesity predisposition may not be vulnerable to these factors. So again, pointing to the fact that some people may be genetically predisposed with some of these factors really affecting them. All this points to the heterogeneity of obesity and a shift toward understanding it as an umbrella disease category, much like cancer. Indeed, specialists now use the term obesities to signify its different subtypes, which have yet to be nailed down. People on the higher end of the obesity continuum may have a different form of the disease than those on the lower end. So again, science is not totally clear yet how this spectrum exists, but they're understanding that there are different levels and contributions and factors that we haven't really previously considered. So for example, one of the things it mentions as a predisposition or a factor that could trigger obesity is poor sleep and circadian rhythm disturbances. So think of your shift workers, like an ER nurse that has to work nights for the first 10 years of their career, right? This person is predisposed potentially to developing obesity, not necessarily because they're eating significantly differently than they had previously, but because now with these sleep disturbances, with these changes in circadian rhythm, their body has kind of triggered that kind of response, and now they have obesity and they can't figure out how to get out of it. So we've got to understand that there's a lot more to the picture than just what a person is putting in their body and how much exercise they're getting. So many of you are probably thinking now, okay, Morgan, this is super interesting, but I'm not a doctor. I'm not going to prescribe semaglutide. What does this have to do with me, right? My license doesn't include pharmacology, which sometimes I think is great, and so where do I come into this? So first and foremost, I believe that we need to be experts in weight loss, right? If we're going to be experts in any field at all, we need to know about as many options as possible. Not because we are going to prescribe them, but because we need to be able to help our patients advocate for themselves as best as possible with those options. Like when a person comes to us with low back pain and we try one manual therapy technique and one form of exercise, and the patient comes back and there's no change and they're no better, and we check our comparable sign and we're like, well, that didn't do it. What do? We don't give up. We try something else. We try a different manual therapy technique. We try exercises that are based in a different strategy and have different effects. We see what happens because we're experts. We always have options. We can kind of reach into the treasure trove and pull out something new. So when we have a patient who comes in who obviously needs to address their weight in some way, shape, or form from a health standpoint, from a PT standpoint, all of the above, if we've worked with them on all of the possible options, the basic stuff, nutritional changes, exercise diversity, all the pieces that we know about and understand traditionally, and that's not working, if we want to be experts, we need to be able to reach deep into that pocket and say, you know what? I know there are some pharmacotherapies out there. I want you to talk to your doctor about those and understand and know that those can be safe and in a really effective way for people to not only lose weight, but change that physiological set point that this article was talking about. Now, secondly, honestly, as PTs, most of us are fitness forward humans. We eat healthy, we exercise regularly, we can maintain a really healthy body weight. And so this personal experience really biases us to believe that weight is always under our self-control, because for many of us, it is. And so that internal personal bias kind of tells us or feeds into our perception that for everyone, it is under their control, because for us it is. So that's a thing that we've got to kind of get past, right? Because if we're going to talk to our patients about weight, we have to understand that it's not always a control issue. It's not always this choice. It's a disease, and we've got to consider it as such, because that will really change our approach with patients. How many people have gotten on this podcast and talked about patient expectation, or how our underneath beliefs as clinicians will show through to our patients in terms of how much we believe in a therapy strategy or a technique, and how that weighs into if it works or not, right? So we have to know that no matter what, if we internally believe that a person has total control over their weight and they're just being lazy or they have no self-control, that's going to show through in our treatment and in our communication with our patients. So we as practitioners have really got to step back, internalize the fact that this is a disease, that we have many variables in treating, and be sure that as we're talking to patients about obesity, there's no judgment showing through. right? Because a patient that comes in that feels that you are judging them, or that you underneath think like this is just what they need to do, they just need to stop eating as much, they just need to stop going out for meals or whatever, that may be a thing, but if that shows through to your patient, you're off the charts. They're not going to trust you. They're less likely to open up. You're less likely to get to the bottom of what's really going on. So we've got to be sure we start perceiving this, as I said, more as a disease and not just as some lifestyle choices, right? Because when patients know you care and know that you're compassionate and open and willing to talk with them and that you're not judging them, it changes the game in every level, right? And we know that as clinicians, when a patient trusts you, and it really changes what you get to learn about their lives. So we've got to change our understanding regarding obesities as diseases, not just lifestyle choices, because it will help us not only treat our patients more compassionately and kind of our take on it, but also more holistically and appropriately. When it's appropriate, again, to refer out, we do. So let's do that also for obesity, especially when it's really impacting the person's overall health and life. All right, and as fitness forward professionals, I think it's also important that we really stop placing blame on our patients who come in who have obesity or who are overweight, because that shows through. It's like no one would walk in and say like, oh, well, also I have cancer. And you'd be like, oh, as if you were blaming them. But I think that's what shows through for a lot of us when we are actually talking to patients about obesity. So we've got to curb that. So I hope that information was helpful. I hope you all can kind of think about that and better strategize and talk to your patients more holistically. The song of the day, I know you've all been waiting for it, is called Eat Your Rainbow, and it's by Kids Learning Tube. I'll post a link on the Facebook group, but if nothing else, look it up. It's real awesome. Anyway, have a great day, everybody, and we'll see you next time.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.